Coffee with Coker is a healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape.
Welcome to another episode of Coffee with Coker. And today we have a recurring guest that's been on podcasts a few times, Alex Kirkland. He's one of our Nashville team members who is one of our key leaders on all things physician compensation, design, strategy, etc. So that's actually what we're going to be talking about today, which is physician comp, some of the latest trends, and really just what Alex is going to talk about is kind of this roadmap in terms of designing and managing physician compensation models for physicians. So we're going to dive into that really quick. Before we do, I always like to cover some housekeeping items, just appreciating everyone for listening. We encourage you all, if you found this helpful, feel free to check out all of our podcast episodes. You can find them and listen to them for free at coffeewithcoker.com. You can find all of Coker's research, insights, and thought leadership pieces at cokergroup.com. And follow us on social media. And subscribe to our email list where we send out very informative thought leadership pieces, usually weekly. And so there's a lot of really good resources there for folks in this particular area of the industry. But with that, thanks, Alex, for joining. And I want to dive right in. Maybe just start by talking about, when you talk about the physician compensation roadmap, what are you really kind of framing there?
Hey, Mark. Well, thanks for having me. And in terms of the physician roadmap, I think there are 1,000 different ways to pay a doctor, and all of them, many of them may be viable. In order to understand where you're going, I think it's first important in terms of physician compensation. I think it's important to understand where we're expecting to see shifts in the physician workforce. And so we're tracking studies that the Association of American Medical Colleges puts out as far as physician supply and demand studies. Separately, the Physician Advocacy Institute has put out some studies showing where we've seen a big increase in employment as opposed to private practice. And what's interesting in those employment studies is that while there's still a continued uptick in hospital employment, there is a large uptick in what they're called corporate employment, where payers and other disruptors are employing physicians. And I think that understanding those dynamics that physicians are migrating towards is appealing. I think that goes back into the shifting demographics that we're expecting, what physicians are looking for. And once that's understood, then it's designing the right compensation model, which we have thoughts about.
Yeah, exactly. And ultimately, that's why we're talking about it, because we work with so many of our clients on designing different plans and models for paying their physicians under different types of arrangements, and obviously within fair market value guidelines and any regulatory requirements that may be out there. And like you said, since there are so many different ways of paying doctors and providers in general, sometimes I think navigating that roadmap, it could really be a challenge in and of itself, but not picking kind of the right, or not taking the right path and understanding some of these, market forces, as you referred to or alluded to, can, result in significant financial impact, positive or negative, I guess. And that's ultimately, you want a plan that obviously falls within the boundaries of compliance, but one that also maximizes, financial, financial return output, if you will, that is, best for both parties, the employer and the provider themselves. So maybe talk about, you mentioned disruptors, but, maybe what are some of the key market forces or industry forces that we're seeing right now that, those employing, paying physicians and providers are trying to navigate or will maybe have to navigate here in the future?
Well, when plotting out what the roadmap of compensation looks like, I mentioned that it's important to understand the types of providers that you'll have, what the demographics are. We're expecting to see a shift, and all indications are that it's going to continue. We're going to see more and more health care consolidation, and I think that may be more and more employment opportunities for physicians as opposed to private practice. Not saying that there's private practice is going away by any means, but I think that during the pandemic we saw a large uptick in employment as physicians were looking to be shielded from risk factors. There's a lot of physicians that are nearing retirement, according to studies. Younger physicians coming in may look for some of those sign-on bonuses, loan repayment packages that employers can offer. And as employers are thinking about designing compensation package, the number one factor to be considered of is what type of revenue stream do they have? We hear so much about value-based reimbursement, and we expect to see a continued push towards value-based care. All indications are that it will continue and grow, but it may be a long time before it overtakes fee-for-service as the dominant revenue stream. And the key to a sound compensation model is to keep physician incentives proportionate to the revenue streams so that behavior is aligned with those funding sources. And I think that's a major thing to be aware of, is what type of funding source are you working with? And if it's fee-for-service is driving the bolus of those dollars, a work RVU model works very well for that. It's payer agnostic, and the hospital or the employer bears the responsibility to collect, which shields the physician from financial risk, something that physicians may be seeking in this post-pandemic world.
Yeah, and the other thing about RVU models is they're pretty, I shouldn't say black and white, because there's certainly complexity in gray areas, but relatively speaking, they're pretty trackable. Let's just say you have objective mechanisms to track, to measure, and incentivize. Whereas some of the other things that are a little bit more, maybe a little bit more subjective, or there's some ambiguity there. I think, well, I'll ask you, is the industry still trying to kind of figure those things out, whether it's a quality-based thing or time-based, something, whatever it may be, that's maybe not quite as objective as RVUs? Does that still continue to evolve?
Still is, and there's lots of ways that organizations go about it. What our guidance has been in developing a work RVU driven compensation model is to allocate incentive components of a rate per work RVU into different buckets. And so you can determine how you may want to spend those dollars. And that kind of allows for the organization to understand what their physician compensation spend may be, control it a little bit more tightly. But we do think it's important that while the compensation is mostly driven by work RVUs, there's a value-based element within that. And that may be funded based on work RVU generation. And so a lot of what we're seeing is that organizations, they're in fee-for-service environments, but a lot of their fee-for-service is becoming fee-for-service with strings attached. Even Medicare's merit-based incentive payment system, the MIPS program, it's fee-for-service with value-based strings attached. We'll give you fee-for-service reimbursement, but there may be adjustments on that pending quality performance scores, whatever is reported and reported. And then how you define what those metrics are, that's a whole nother ball game, something I'm happy to talk more about as far as going about and developing what those key metrics are. And there's certain factors to consider. But again, it goes back to having most of the compensation driven by work RVUs if you're in a fee-for-service environment, but having some element and likely allocated from that rate per work RVU that goes towards the achievement of quality performance.
Yeah, maybe it may be helpful for our listeners, for folks in organizations that are thinking about, or maybe they're in the process of navigating the design or the strategy behind either existing or future provider compensation models, but understanding without getting into the too granular of detail. But what are some of those metrics and inputs that we typically work with our clients on, or we would recommend at least considering and maybe doing some analysis around?
Not to cop out, but it always goes back to it depends.
Yeah, sure.
What does it depend on? Likely where you are on your value-based journey. And so for organizations that are early in that going down that path, you're maybe in a crawl phase as opposed to trying to get to where you're walking and eventually running. And so for those earlier organizations, maybe you're focused on just the idea, and it could be process-based metrics, closing charts. Patient satisfaction is a big one that organizations often initially focus on. And I think that those are good to put in place to get physicians acclimated to this new structure, so that over time, you're likely going to have an annual review of how those metrics should evolve. And over time, you want to replace those that you're doing well on with other metrics where you want to pursue improvements and see betterment within the organization. And that's a big considering force. But how you are able to get that data and track that data, it's very important as well.
Yeah, I guess that's a very good distinction to make, because you may have the best ideas and intentions around all the different things you want to track and measure and incentivize, but if you can't genuinely track and document it, then it's kind of like, well, you're obviously, it's pointless to be trying to talk about it at that point. Maybe to your point though earlier, kind of going through that crawl, walk, run process where, you start maybe, and you can help me with percentages here, but maybe 10% of the compensation, of the total compensation, it has a value-based component to it. Whereas some organizations that have really been in, pursuing this, the value-based piece for a while and have been able to effectively implement it and grow it, I don't know, could it be 50-50 for some?
I think it goes back to the type of specialty, the ability to influence key metrics or control costs, and then how the reimbursement is structured. And so if it's heavily fee for service, I think that, starting as low as 5% may be appropriate. And just starting somewhere allows for a conversation to be had. And so I think what a lot of organizations struggle with is, hey, we don't even know where to start. And we're not, and so as a result, if you don't start, you don't even discuss it. You're not making improvements on tracking more information and more data so that you can improve upon it. And so a 5% starter at least allows you to start a conversation. And it may be that that's where specialists are targeted, just 5% of their compensation, which could be meaningful. And I think that's another factor, is you want it to be something that's meaningful. And on the primary care side, maybe it is more than that.
Yeah.
We do see organizations that go to 50-50 work RVUs versus maybe a panel-based approach within the other 50% of the funding score or the funding source, where it's per member per month or per member per year driven on those rates within primary care. And that's going to go back to the risk game that the organization is playing. Maybe it's a heavy Medicare Advantage population that's driving a lot of reimbursement. And so there would be other considerations to do around that, as far as how would you tailor the metrics, how would you tailor the adjust for patient acuity, all of those things. Those would be things to consider in terms of how you design the incentive and the metrics that you would measure.
Yeah, that makes sense. I want to go back to one of your earlier comments, talking about some of the disruptors and the trends there. Talk for a minute, if you don't mind, about why these disruptors are really, being able to disrupt the convention. But some of the drivers, because whether you're a hospital or health system employing providers, or like you referenced the corporate employers that was mentioned, I think, in the study. Talk about that as an industry trend, and maybe, like you said, private practices by no means are going away, but if the numbers are starting to shift at any significant level, then that's something that really is going to have some downstream impact on the industry. Talk about that if you don't mind.
Yeah, well, I think that the disruptors they come from lots of different backgrounds. One of the major forces that we're seeing is those that are playing the risk game. There were some controversial Medicare Advantage articles that were written in the past 2 years about this topic, but all about trying to deliver care at a cost beneath the benchmark. Where is that benchmark set? That's going to depend a lot on documentation and a lot of other socioeconomic factors. And so we're seeing a growing number of disruptors come in, recruit primary care, try to gain a lot of market share, and make sure that they are documenting everything possible to reflect this. What they would argue would be the right severity of their patient population, which would increase their cost benchmarks. And so as long as they can manage within that, then they're going to be able to recognize surplus. And that's been beneficial for a lot of organizations. And it's developed into wholesale business strategies of some organizations. Now, and I think that's we see organizations have a lot of success under that model. And there is risk associated to that because it takes CMS largely administering the Medicare Advantage program or setting the rules that the private payers then bid on. To the extent that they change those rules, it could have a detrimental impact to the whole business model of some of those disruptors. So that's something to continue to watch as far as how that evolves.
Right. The risk thing, I think, is definitely a trend we're seeing. I mean, we've seen it all across the board in different ways, right? I mean, even if you go back 10 plus years, the early on kind of alignment trend, physicians and hospitals, aligning more closely. A lot of that was about taking risk off the table. And then now you got a whole different kind of risk, discussion around risk with, some of the payers getting more involved and some of the things you just talked about. So I think we're still seeing the impact of just risk management and taking risk off the table where you can, and maybe gaining from some risk in other areas continues to be a let's just say a growing trend, I guess.
That's what some of these disruptors in the risk game are doing, is they're trying to be able to recognize that arbitrage in the amount of cost that it took to deliver care versus their benchmark. And how they're being successful is that they are paying physicians market-based rates and incentives. And so they're bearing the risk, but are recognizing a lot of upside. And so, more and more data is coming into play. A lot of actuarial work is coming into play, trying to be able to target specific populations, which could argue, you're going to go after certain populations because you think you can deliver care cheaper there, those types of things. That could be controversial in and of itself. But a lot of moving pieces in that regard.
Yeah. Are you, maybe there's no or not enough data to have kind of an objective perspective on this, but even if you think about the work, anecdotally, the work that you specifically do with clients and the work Coker does with clients for hospitals, is this impacting them yet? These disruptors at any level of significance in terms of shifting or reshaping local healthcare markets? Is that something that hospitals are having to deal with, or is it impacting them negatively at all at this point?
Yeah, it depends on the market, but we absolutely see it. And so we have worked with hospitals to change their reporting of what the compensation package may look like. And it may be that if a physician is going to be allured by private equity, let's say, Part of that allure is that there's a big upfront payment or the potential for such. How does the hospital compete with that if they're only buying assets
Right.
in the physician practice? And so we've helped hospitals kind of position their value proposition and show economics, over a 5-year period. What does this look like compared to the upfront payment that you're getting? And if you are getting a big upfront payment on the private equity side, it may come at the cost of reduced earnings in a future period. And so how does that look, over a 5-year horizon? And what we're seeing oftentimes is that hospitals absolutely compete with that. And so it's a matter of helping the physicians or the prospective investors understand those dynamics and what the different components mean, and the timing of payments, some of those factors.
Yeah, that your example is the one I was thinking of too, or kind of the situation I was thinking of, because I know we've definitely had to work with clients where they are confronted with, let's just say, a large upfront price tag that is very attractive to a seller. And historically, hospitals have been very limited on their ability to do something like that or to compete with something like that because, a lot of them just don't have that money. I mean, if you're talking about certain areas, certain markets, that's just not, something they can take a bite out of at this point. But also the regulatory constraints. And I feel like, and feel free to disagree with me here, I feel like we've started to see some of the maybe the specific laws haven't shifted greatly yet, but we've seen even a slow evolution towards some of the shifting and the regulatory guidelines, let's just say, even if it's informal, in terms of, hospitals having a little bit more flexibility, because, something like that in certain markets, 1 or 2 large transactions led by an outside party can really shift how a local healthcare marketplace functions.
It absolutely can. And I think there's several factors at play. One is that I think for the Federal Trade Commission, the FTC, to be on their radar, there's a threshold of $100 million,
right,
transaction threshold. And so some of these deals get done that are underneath that threshold that just don't catch regulators' eyes to the degree that hospital transactions would, because it may be underneath the threshold.
Correct.
That's something that's been discussed. Whether or not that threshold changes, that's up for speculation. But it's absolutely something that local hospitals and markets need to be aware of. And you're right; these deals they can be disruptors in those local environments. And so, knowing how they can compete, what they can offer, and how that can be done within a regulatory framework is very important. And a lot of times, the way that you're able to articulate that message to the physician can be very impactful, and something that we've been able to support a lot of our hospital clients with.
Yeah, and just for people's listening, for so they fully understand, the FTC covers, which that threshold used to be, I think, pretty significantly lower. But that only covers certain types of transactions. There are other regulatory requirements and constraints for transactions between a hospital and a physician, and those are I would say more stringent, and they're looked at very differently and handled by a completely different part of the federal government. So there's a lot at stake for these hospitals, these local markets. And it's not to say these disruptors are bad. That is not our take, because listen, Coker works with all kinds of different provider organizations. And there are certainly more these days, far more than there used to be, beyond hospitals. And but the nature of these transactions, again, do impact the local healthcare market. And I think in the long run, this is just me talking here. Again, feel free to disagree. In the long run, we'll see, I think, a positive impact in terms of things like quality, access, because I think that type of competition typically drives those types of things, generally speaking, in economics, right? But I think when we're talking about healthcare, we have to, it can't be this unfair thing, an unfair advantage for one type of entity, and then constraints on another type of entity. When you start to, I think in that case, you may start to see negative impact, right? Too much gain on one side and loss on the other, which then results in an imbalance, and that trickles down. And we're talking about something that can really impact a local market.
Yeah, I mean, to the extent that we see improved quality and access, I think the way that happens is that you have to track it and improve upon it, incentivize around it. And so I think that goes back to assuming that you're in a fee-for-service market, the work RVU model is appropriate, but having an element or allocating a portion of that rate per work RVU for quality initiatives is so important, because you can begin to implement something that you have to track and begin the conversation about. And that's how you'll drive those improvements in quality and access.
Yeah. One last thing I wanted to ask you about, you mentioned earlier, even like particularly when you talk about those in the risk game, payers, et cetera, even really getting in the weeds, like at an actuarial level, which, entities like payers have been doing for a very long time, and they can get really proficient in understanding the numbers, the data, the productivity, those types of things. It just made me think of not all organizations are able to do that and to really get proficient and really in the weeds. But that is becoming something, or maybe I should ask, is that becoming something more common for hospitals that they're having to get better at, being able to capture certain data elements and then doing the work to really understand how they can share in the risk and benefit from that, and make sure that their model is designed to obviously work for all the parties involved. And then that's part one. And then part two to that question is, again, we're talking about data and some of the things driving compensation. I always have to ask when we're having these conversations, as we've had in the past, where are we at with the surveys and the things that are really driving the benchmarks and the measurements and what the market rates are? Is that continuing to evolve, or are we long past that?
Well, let me answer that. I'll just jump onto that last question and then work backwards.
Yeah.
So as far as the surveys are concerned, they come out. So when we say surveys, we're talking about the Medical Group Management Association, the MGMA, the Compensation and Productivity Survey, the American Medical Group Association survey, Sullivan Cotter, and there's others as well. Those are on the verge of coming out. The 2023 surveys will be based on 2022 data. The key thing to be aware of on those is it's based on actual information that's reported. And the Medicare Physician Fee Schedule saw a major change over the past several years. Different organizations have adopted that at different paces, where a lot of organizations have stayed frozen on the old work RVU values under a prior Medicare Physician Fee Schedule. And so which work RVUs are being reported in? What we've seen to date is that while some of the survey sources try to segregate, these are the work RVUs that are being reported into the old and new fee schedule. You've got a number of organizations that are making transition to the new fee schedule at different points in the year. And so maybe they have a June 30 fiscal year. So half the year they will have reported old work RVUs, half the year they would have reported new work RVUs. So it's just a big mixed bag. We're very anxious to see what the surveys look like. I think MGMA is the first one to come out here within the next few weeks. And then over the summer, some of the other surveys will begin to be released. It's something that we will absolutely keep an eye on. But what we're expecting and advising clients on is that for so long, we've been beholden to these surveys to set compensation, work RVU rates, and these other factors that we use to design and administer plans. And often it's been used even though we have a difficult time, or healthcare organizations have a difficult time affording those rates. And so how do we break away from that? And so this volatility that we're experiencing right now in the surveys, it may be an appropriate time to look at, to understand what your organization's collections rate per work RVU is. Is that going to play a factor into how you set a rate? To be more mindful of what your economic would support. Certainly, you need to understand what your competitors are doing, but the survey data is very much of a mess right now, and it'll be interesting to see when everyone's caught up and is reporting on the same work RVUs, how the survey data looks at that point. But it still may take some time to understand that.
Mm. Yeah, that makes sense. And you kind of you kind of touched on my first question, but I'll just kind of reframe it. But are hospitals having to get more proficient in not just collecting certain data, but really understanding, dissecting it, and analyzing it at a more proficient level in order to compete with some of these other types of organizations that that's their entire business model, or that's very much embedded within their business model. Is that new for hospitals, or is it kind of a non-issue because they can stay on the same, forgetting for a second the issues of the survey, but they can continue to go down the same road with the same models they've been used to historically?
Well, collecting and tracking data is one thing. Understanding what it means is another.
Right.
There's a lot of insights that can be gained from claims data, and I think typically hospitals will not have will have a limited, robust analytics team to do that. Payers have a lot of information that you can collect, and so what we see is that more often there are third-party companies that are popping up, and that they are sponsoring ACOs, accountable care organizations. They are driving some of those ACOs, or that they create tools that can be utilized. The EHRs are developing tools, continue to have tools, add-ons that can be utilized for some of those insights. But I think it is, an emerging space where some hospitals look at some of that data. It may be within a population health department of that hospital or something else. But I think that right now we tend to see that they are partnering with other firms for that insight, or paying for that data in other ways.
Yeah, and that's exactly what I was getting at in terms of the resources a lot of hospitals have, or maybe just aren't able to acquire to get into that level of analysis and granularity in order, to your point, to understand the data. I think that seems to be a new trend in hospitals. Many of them are getting much more advanced, but again, so many of them out there just don't have that capability for whatever reason. But which I'll close out by giving kind of a shameless plug to your points about the changes, the significant changes in the Medicare Physician Fee Schedules over the last couple of years, and some of the other policies that have come out. One of the things we're doing with our clients that I know, Alex, you've been very heavily involved in, is working with them just to understand how these changes that have been made at the policy or federal government level kind of flow down into understanding what are the differences here. How are we able to, or can we use the survey data? Can we tweak that data in order to incorporate some of these changes, the impact of some of these changes? One of the things we've done is a very simple impact calculator using the changes in some of the E&M coding requirements over the last, 2 years now. People can find that on our website. But yeah, some of it just starts with an analysis of understanding what are the impact of these changes, and then that may influence where we go from there.
Yeah, I appreciate those comments, and if it's okay, I'd like to make a closing comment on what we see being successful. And that, we talked about the physician compensation roadmap and what that looks like and how it needs to align with your funding source. Changing physician compensation can be very difficult. And Where we've seen organizations be successful is those that take a good approach on that, utilizing, hey, this is the lay of the land. This is the landscape of macroeconomic changes that we're seeing, disruptors, what they mean. These are the financial constraints that we need to play within. And this is what the vision that we're casting. And having a change agent, someone that can, like where we've come in and help them articulate what that vision is to physicians, it's helped them bridge that gap and get onto new models or contemporize the manner, the structure in which they're paying their physicians to something that's going to be market competitive and going to drive the behaviors that are being sought and things that physicians would respond well to. So we've it's fun work to do, but it's challenging in that regard as well. But there's a lot of education around data and laying out the landscape that we do to help the right stakeholders understand the situation.
Yeah, well, I think it's a good testament to, or a good clarification, if you will, regarding a lot of the work that you and your team and Coker as a whole does with our clients. Because while on the surface, designing a compensation plan may seem pretty like it's a straightforward, relatively straightforward exercise. Just we've only talked about some of the complexities here today. I mean, there's countless things that, and each organization is different, obviously. So every client is like a new, different challenge. So I think that's extremely helpful. Some context there, maybe, and hopefully a good recommendation for organizations, whether you're a hospital or any other type of healthcare services organization that employs providers. Navigating this is a complex thing, and it's an ongoing thing because as the market continues to evolve, so do the plans. And so, again, I think that's very helpful, and I appreciate your insight here. Again, I want to plug for our listeners. I want to plug Alex and his team and the other folks here at Coker that work on this and a lot of other things. We put out a lot of good content that hopefully helps folks understand some of this stuff better. And then, obviously folks can reach out to Alex and any of us here at Coker and with questions if you need Alex or one of our team members maybe to help with something that's more specific or nuanced to your organization. We're always happy to do that. So we'll make sure that information is provided in the notes for the show. And but I know we'll continue to talk about this. This is something that only continues to be a hot button topic for all of our clients. So I appreciate your input, Alex, and we'll look forward to continuing the discussion in the future.
Thanks so much, Mark.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us in a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback. And we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.